Thank you for that very interesting and, for me, very enlightening discussion about choline. I'd like to invite our speakers to come up now. We'll be taking questions on your presentations at this time. So I'm going to go ahead and start with the first question, and this is for Dr. Caudill. So currently, in regular practice, I'm a clinician, we don't screen for adequacy of choline intake in the diets of our patients. And I did a very scientific study when I knew I was going to be presenting this, and I asked all of my colleagues, the residents, the medical students, what they know about choline, and it pretty much is nothing. So given our lack of awareness and the fact that this seems to have such a significant impact on clinical care, do you think this is something that we should be screening for in our routine prenatal labs?
So I think you're right in that choline is an unrecognized essential nutrient that does play a critical role in fetal development. Many people don't recognize that, and I think that yes, asking a woman whether or not she incorporates animal source foods in her diet would be actually a good start at understanding whether she may be at risk of not only not enough choline, but also B12 and some other nutrients that are kind of localized to those types of foods. So I think that would be a good starting point. One of the challenges with choline nutrition is that we really don't have a good biomarker. And so you can't draw blood from your patient and identify whether they are choline deficient. So knowing about their diet is actually a really good first step. We don't have a biomarker as of yet. And that's because when choline is consumed and it enters the bloodstream, it's rapidly taken up by tissues. It doesn't sit out in the bloodstream like some other nutrients do. And it's very hard to change fasting concentrations of choline, even with supplements. But if we do studies where we look at choline levels in the blood right after they consume a meal, like up to 6 hours, we can see it's very bioavailable. Blood levels are rising. But if you wait any longer than that, you're not going to see it because it's in the tissues. So it's challenging right now. But I know Stephen Zeisel is working on a study with the goal of coming up with a good biomarker for choline.
Thank you. Okay. We'll take some questions from the audience.
Thank you for two wonderful talks. My name is Emily Oken from Harvard Medical School. For Dr. Caudill again, actually, two questions. One is if you could comment on the food sources for choline, more specifically, I guess you learned a little bit to animal sources, but I remember, this is a few years ago, but looking at the sort of pamphlet that was given to pregnant women in my health system, and it talked about eggs and choline, but it was sponsored by the Egg Council, so I'm just wondering how much of that is the Egg Council versus other things. And then the second question is just a thought that I had, given the key role of the liver in choline metabolism, and we have so many women now who might have fatty livers and fatty liver disease with being older and having obesity or insulin resistance, if you could comment on whether that affects the metabolism of choline.
Sure. So in regards to the first question, so I can just give you kind of some ballpark numbers. So some very good sources of choline would be egg yolks, so eggs, but it's found in the egg yolk. Beef, chicken, fish, most animal flesh foods are going to contain about 100 milligrams of choline per serving. That'd be 1 egg or about 3 ounces of meat product. And that would be then in contrast to some very good plant sources, which are going to provide about 30 to 40 milligrams per serving. And that would be your cruciferous vegetables, legumes, and I mean, there's really not that many. Those are your two best plant source foods of choline. So the majority of choline is found in our animal source foods. And in regards to the second question, I actually added that bullet about phosphatidylcholine being required for VLDL biosynthesis and the export of fat, given that we are seeing more and more pregnant women with fatty liver. And it is very likely, though there's not studies that have been done to show this, that their requirement for choline is going to be higher in order to export that extra fat out of liver. And of course, make it available to the periphery, but also to the developing fetus. So that would be my view in terms of hypothesis that overweight women or women that are developing fatty liver are going to have a higher requirement for choline.
Thank you.
Hi, I'm Carolyn Hightower from the Vitamix Foundation. I was wondering if you could comment on the level of choline in formula contrasted to breast milk.
Yes. So the level of choline in formula depends whether it's cow-based or soy-based. The cow-based formula, the level is very similar to what we see in breast milk. The soy-based formula is lower. The forms of choline that we see in breast milk versus formula is different, whether you're looking at both either cows or soy-based formula. And we do have data to suggest that choline bioavailability is higher in breast milk than it is in formula.
Hi, Jessie Silverman, Center for Science and the Public Interest. I have another question for Dr. Cottle. I was hoping you could comment with your opinion on the appropriateness of the AI for choline during pregnancy. And I thought it was interesting that it is an AI and not an EAR, and whether you think that there are sufficient data to update that, and and I understand that the DRIs are kind of traditionally developed in mind to overt deficiency, and that's really not the kind of outcomes you're talking about. So
yes,
I'm sure you have thoughts on that.
Yeah, thank you for bringing that up, because I think that is the challenge that historically RDAs or AIs, RDAs, have been about preventing deficiency, although we are moving now towards optimizing certain health endpoints. So I think that if we were to take the approach of optimizing certain endpoints, then we could use data such as what I presented there, where we're showing that 930 appeared to lead to better health outcomes than did the 480. And so, so based upon that data, if we just stick with an AI, it would appear that the AI currently is too low. And I would be for bumping it up. Then you face the challenge of, if women aren't right now meeting the AI, which is only at 450, how are they going to meet an AI, say around 800 or 900? And that's where I think the supplement use would be very helpful. I think this might be the same case as iron, that in order to achieve these higher intakes that appear to be beneficial, you would need to supplement the maternal diet.
I'm going to interject a question for Dr. Lemairs. Okay. So I actually have two questions. My first is, why do you think we've migrated so far away from the original 400 microgram dosing of folic acid to these larger, increased preparations? And then my second question is, I know we were talking about low-risk populations for this talk, but what are your thoughts on the appropriate dose of folic acid for women who are at increased risk for neural tube defects?
Okay, thank you. Those are both excellent questions. So with respect to the formulation, I think it's more a historic thing that the prenatal supplements in the US and Canada have contained 800 microgram. And so now it's just that we want to adjust the supplement composition to what the recommendation states. So it would be a lowering. And with respect to women at risk of neurotube defect, you mean those that have had a
prior pregnancies affected?
Yeah, that's a very tricky question, difficult to answer scientifically. So here again, historically, the MRC trial in the UK that showed that the recurrence of NTD can be prevented through the use of 4 milligram of folic acid periconceptually. the dosage of 4 milligram was chosen because that was the dosage the pharmacist had available when the physician was running the study in the hospital. So now we have the evidence that 4 milligram are beneficial. To now do a dose-dependent trial using lower dosages would be ethically not correct. So will observational studies down the road inform us that, well, there were women who have had recurrent that had a previous neurotube defect and had no recurrent entity with lower dosages? That would be, through monitoring and long-term observational studies. But at this point, there's no RCT that could be done on these.
Thank you.
Johanna Dwyer, ODS, NIH. My question is for Dr. Codell about the prenatals and an idea of what level you think would be appropriate, and also the gymnastics of all of this, because you've got people adding DHA and multi-packs and all of the paraphernalia. How do you get it all in?
Right. And that's been the challenge, I think, for prenatal supplement companies. It's not that they haven't wanted to incorporate choline into their prenatal supplement, but there's just simply not enough space. So the choline AI, remember, is in milligram amounts. Most micronutrients are in microgram amounts. They're easy to fit into a single capsule or pill. Trying to put choline into that same capsule is really just not possible. So what companies, from my understanding, what they're starting to do is look at whether they can combine choline and DHA into a single capsule. That would make a lot of sense. There seems to be synergy between those nutrients. Right now, in the United States at least, it is standard of care to recommend 200 milligrams of DHA. So that could be a place that you could incorporate choline. And in terms of the amount, I would propose a range between 350 to 500 milligrams in a capsule that was meant to take one time per day. And I'm kind of waiting for the question about, are there any adverse effects of taking too much choline?
Go ahead.
Okay. So there is an upper level of tolerance for choline. It's set at 3,500 milligrams per day, which is well above the highest dose that we used in our studies at 930. The risk of taking too much choline is fishy body odor. And that's because when choline's not absorbed in the small intestine and it reaches the large intestine, we have bacteria down there that convert it to a smelly molecule called trimethylamine. And that trimethylamine, if it's not converted to a non-odorous compound, can be smelt in sweat, urine, and any other saliva. So that's a big downside. And then the other downside is that it can promote low blood pressure. So low blood pressure. Acetylcholine, one of its functions is to slow the heart. And so taking an excessive amount of choline, which you could only get through supplement at that 3,500 milligrams, would promote hypotension. So we don't want to go anywhere up there. But more recently, scientists are concerned with actually the production of trimethylamine and trimethylamine oxide. And so how this story got started was Cleveland Clinic, investigators finding that those who had elevated circulating TMAO in their blood and they'd had a heart attack already were at greater risk of having a second heart attack if their TMAO levels were higher. And so that's really led to a series of studies showing that in sick populations that this higher TMAO associates with greater risk of a variety of different diseases. But I think we need to take a step back and just remember that that's an association study and recognize that there are many confounders that we need to be thinking about when we think about the choline TMAO health risk story. And the first is that the microbiome composition plays a major role in TMA and TMAO production. And it turns out that there are certain microbes that are associated with greater risk of disease that actually have the enzymes to convert choline to TMA. So what we might be looking at is those that are more diseased have a different microbiome. And this microbiome is generating more TMAO, but it's the microbiome that's directly affecting disease risk, not circulating TMAO. And the other thing to consider is that the kidney plays a role in TMAO excretion. So 95% of TMAO is excreted in the urine fairly rapidly. And so those with even subclinical kidney impairments are going to show an elevation in TMAO. And those are the patients that are more likely to have problems, that related to their heart disease. So those are two really important confounding variables that we need to think of. But I think more simply, just to recognize that consumption of fish increases circulating TMAO levels 50 times more than consumption of choline-containing foods. And so if indeed we're going to recommend women not to take choline because of its TMAO raising properties, we'd have to tell them not to take fish. And I think that there's decades of research showing beneficial effects of fish. So that's just also something to keep in mind.
Thank you. We have a couple of questions from the webinar audience. So the first one is anyone looking at the link between folic acid supplementation in foods and the increase in the reported glucose tolerance? Gluten intolerance. So can you talk about, women who are
Sorry, can you repeat
avoiding?
the beginning of the question, please?
So what is the link between women who are avoiding foods that are high in gluten or avoiding gluten completely and then folic acid, sort of meeting their folic acid requirements?
Okay, yeah, that's a good question. So the current fortification practices in the US are, and in Canada, is to fortify grain products, white wheat products, and those are the products that also contain gluten. Also, breakfast cereals are fortified with folic acid, and they're also often avoided unless it's rice cereals or other cereals. But those are all products that contain high amounts of gluten. So if individuals avoid gluten containing foods, they also avoid the foods that are currently enriched or fortified with folic acid. So with that, they would have lower folic acid intake. However, thinking from the perspective or the guidelines, also should these then supplement more, or who should supplement with folic acid? I think it's across the board that everybody should supplement, also those with or without gluten intolerance or avoiding those foods, because what the enhanced data have shown that the enriched foods currently contribute with 150 microgram of folic acid per day to the folic acid intake. That's still not meeting the 400 microgram. So if somebody avoids the foods and has 0 microgram from fortified foods, they still need to supplement. And so it's, again, my recommendation that everybody post-fortification should supplement.
Another question also related to your area of expertise is, given food fortification, I just lost it. Basically, what they were asking for you to do is to explain the difference between the reduction in neural tube defects between Canada and the United States.
Okay, that's a good one. And I'm not sure I would have the answer for that, to be honest. I believe it's also related to the different, how the data were collected, the birth statistics, what data are available, the birth registries, but I admit I need to pass on this. Do you know the difference?
Got one more question, we can. Sure. So this is for Dr. Caudell. If I can just find it again. Where am I?
I have a question for Yvonne in the meantime, so, or even for the audience. So, because of the MTHFR story, more and more supplement companies are putting in the bioactive form of folate in their prenatal products. So they're putting in methylfolate versus folic acid. Yet at the same time, it's the folic acid that was shown to reduce the incidence of neural tube defects, not methylfolate. So, Yvonne, should we be concerned about this trend? Or do you think that they're going to be biologically or physiologically equivalent? I'm giving you a really hard question.
Yeah, and I actually took that topic out of my talk. It was already long, But it's an excellent question. And I think, it has been, like you said, the trend has been shown now. So, where do I start? So, they are biologically different. The one is an oxidized form, the other one is a naturally occurring form. So higher bioavailability of the 5-methyl form has been shown previously. It doesn't need to be converted. Folic acid needs to be converted once it enters the metabolism. And that's actually a study I did during my PhD now way back. We supplemented women with 400 microgram folic acid versus the equimolar amount of 5-methyl tetrahydrofolate. And we showed that they had higher red blood cell folate increase in those that received 5-methyl tetrahydrofolate, but there was an increase in both groups. The other part to that is, sorry, I'm blanking. So the other part to that is with respect to the neurotube defects, like you said, so the evidence showed that 400 microgram of folic acid was adequate, was sufficient to reduce neurotube defects. And because this specific form was used, we currently feel it's unethical to recommend a different form because it was folic acid specifically. However, it also needs to be noted that neurotube defect, the lowest risk is at this threshold of 906 red blood cell folate concentration, and women can achieve this level of red blood cell folate concentration with supplementing the natural form. Does that mean that they can take 5-methyl tetrahydrofolate to prevent neurotube defects? I don't want to say yes. I don't want to be the one that has caused it. And that is because mechanistically, folic acid, given it has to be converted first, has a different effect on the folate cycle than the 5-methyl tetrahydrofolate. 5-methyl tetrahydrofolate is the form that is required to convert homocysteine to methionine to make more SAM that is required then for the DNA methylation and other methylation reaction. However, folic acid, when it enters the metabolism, it's first reduced, dihydrofolate is formed, and then tetrahydrofolate. And at that point, it was shown in vitro studies that high levels of dihydrofolate may have inhibitory effect on the enzyme that allows us to form 5-methyl tetrahydrofolate. So whether high-dose folic acid has that anti-folate effect or may have a different effect on the metabolism, and if that's the regulatory effect on the neurotube defects, that is still not known. And although it's high-level evidence and it's well-established causal relationship between folate and neurotube defects, we still actually don't know and we don't understand the underlying mechanism how folate protects NTDs. So that would be another open question. So I hope I provided some answers in between. Any other questions?
Okay. I think we're done with the questions. So that will be the conclusion of this session. I want to thank each of the speakers for their great remarks here. At this time, we're going to break for lunch. For audience members, there's a cafeteria located in the basement level of this building, and we're going to reconvene promptly at 1 o'clock. Thank you.